KCBS, in partnership with UCSF Health, presents As Prescribed, a weekly conversation with leading medical experts from UCSF Medical Center and UCSF Benioff Children's Hospitals.
Hello and welcome to As Prescribed. I'm Alice Wertz. Governor Gavin Newsom has recently vetoed Senate Bill 90, which would have capped the price of insulin in California. But he vetoed it because he cited the need to address the underlying costs and the long-term scalability of offering insulin at a discounted price to all. And this life-saving drug is important to Californians. Some 4 million people in our state have diabetes. For many, the largest barrier to accessing insulin to address their diabetes is cost. To discuss this more in depth, we're joined today by Dr. Suneil Koliwad. He is the chief endocrinologist at UCSF, as well as an expert in diabetes, obesity, and metabolism. Thank you so much for joining us today, Dr. Koliwad.
Thank you, Alice. I really appreciate the chance to be here with you today.
Truly an important subject. Can you please tell us about the state of diabetes in our state of California?
Absolutely. Diabetes is notable for a few key components that define it. Number one, it's very common. And so the idea that diabetes doesn't quote unquote affect me is not accurate. Nearly everybody at least knows somebody close to them who has diabetes or prediabetes, which is a precursor condition that will oftentimes lead to diabetes within the next few years after its diagnosis. And given how common it is, the second thing that's really concerning about diabetes that should be on all of our minds is the fact that diabetes inexorably leads to complications if not controlled properly. Those complications include risks for cardiovascular disease and heart attack, stroke, kidney failure leading to dialysis, eye disease leading to blindness, and neurologic disease leading to issues even including amputation of limbs. And because of the severity of these complications, untreated diabetes or improperly controlled diabetes has the potential to significantly limit the productivity of the population in a state like ours, as well as produce an immense burden on our healthcare system, given the large number of individuals who have diabetes or are at risk for diabetes. And the final issue that I think defines diabetes, particularly in California, is that the more diverse a population is, and California is an exceptionally diverse population, one that we pride ourselves on, in fact, there are pockets of individuals in specific populations within this diverse state that have exceptionally high risk for diabetes and exceptionally high rates of diabetes. And therefore, one of the key defining factors of diabetes in our state is the notable need to improve equity and reduce the disparities that define these pockets of populations at such high risk.
So why is insulin and getting access to it so important for those who have diabetes? And why is it so expensive?
So that's a great question too. Diabetes comes in two basic flavors. One we commonly call type 1 diabetes. Type 1 diabetes results from an autoimmune insult, meaning that the immune system misrecognizes particular proteins in the pancreas, which is where insulin is made in the body, and attacks one's own pancreas and ultimately destroys that individual's capacity to make insulin on their own. So individuals with type 1 diabetes are inherently, therefore, reliant on insulin as a means to preserve normal life. Without insulin, people with type 1 diabetes would ultimately die from the disease. So for those people, it is essential. The other type of diabetes, which affects the vast majority, depending on the population, perhaps even 90% or more of the individuals with diabetes, is type 2 diabetes. Now, type 2 diabetes is a diverse condition that can often respond to other medicines than insulin. And we give patients medicines ranging from metformin to some of the newer medicines that you've heard a lot about, brand names including Ozempic and Wegovy and Trulicity, that focus on the intersection of diabetes and obesity, which is a driver of type 2 diabetes in our population. However, even in type 2 diabetes, individuals can have the condition progress to the point where insulin becomes necessary as a means to maintain glucose control. And in that context, people with type 2 diabetes start resembling people with type 1 diabetes in that insulin starts to become essential. And therefore, for those people with type 2 diabetes and all people with type 1 diabetes, insulin is necessary. They cannot do without it. And insulin can do what no other medicine can do to normalize blood glucose and prevent the acute issues that are associated with high blood sugar, which can lead to hospitalization and death immediately in individuals with exceptionally high values, and those long-term complications that I already mentioned. And so insulin is essential. Now, why is insulin expensive? That's a more complicated question and a more complicated answer. The reason why insulin is expensive is not because it's expensive to make. It's not because basic insulin is complicated from a scientific standpoint, and therefore it is expected that it should be expensive to produce. Rather, the reason why insulin is expensive has everything to do with the way our healthcare system is set up. Our healthcare system in the United States has a lot of components in the economic model between the manufacturing of insulin and our ability to get it from the pharmacy. And because all of those components have an economic benefit that they derive from how insulin is priced, the pricing of insulin, depending on the type of insulin, depending on one's insurance plan, depending on what state you live in, depending on the pharmacy benefits management company that interacts with your health plan, can be very different. And so because of those differences, some individuals in our country can get insulin very affordably, if not essentially free in some instances, whereas other individuals can get the same exact insulin at an exorbitantly elevated price point. Or some people can get one type of insulin affordably and another type of insulin that might be better for them, only in a very expensive way. And so it's these inconsistencies in pricing based on the economic model that we have in our country that define why insulin is so expensive for some. And that is true in California as well as it is elsewhere.
How can we make care and treatment more accessible and equitable to Californians and beyond?
So that is a really great question, Alice. And I think that you hit it on the head in terms of the key word that you chose to use, equity. The point is that all people who need insulin, and I defined previously that there are many people who absolutely need insulin, they cannot do without it, should be able to get it in an equitable manner so that they don't feel like they're being priced unfairly versus another individual who can get the same exact medicine much more cheaply than they can get it. So with this eye on equity, here are some things that have been done thus far that have gotten us closer to equity, but we're still not where we want to be. So firstly, there is federal legislation on the books to improve insulin price equity. And that is a federal mandate that insulin be priced at $35 a vial and not more for individuals who receive their healthcare benefits through Medicare. So Medicare beneficiaries across the country, including in California, do now get cheaper insulin than they would have been able to get 3 years ago, 5 years ago, certainly 10 years ago. So that is a big advancement because there's a lot of people who need insulin who are Medicare beneficiaries. Secondly, in California, there have been successful efforts, including through lobbying groups that are patient advocacy-oriented organizations, to improve insulin pricing for people who receive their health benefits through publicly funded health plans. And because our state is so large and has such a large number of individuals who do amazing work in our state, who are public employees, community helpers of all sorts, those individuals can now increasingly get insulin priced better than they were able to get a few years back. And so those ongoing lobbying efforts have been successful, and that is another population of individuals who have been brought closer to equity in our state. But as you can see, if you discount individuals who receive Medicare and public employees, there's still so many people in California who fall outside of those groups who are beset by the vagaries of our economic model for healthcare, and therefore are subject to very disparate insulin pricing and inequitable access to insulin based on affordability. And so the real need right now that we have is to address those remaining populations in California and nationwide using as many tools as we can bring to bear to get everybody down to an agreed upon price for insulin that people think that they can reliably and sustainably afford, given how essential it might be to their healthcare.
How far out do you think we are?
So with respect to achieving insulin affordability, I think we're getting closer all the time. 5 years ago, I would not have immediately predicted that we'd be where we are now. I did not necessarily see that we'd be able to get federal legislation, but there is a lot of push, bipartisan push to do better for patients with diabetes, because as I said, whether you're Democrat or Republican, everybody is affected by this disease given how common it is. And I think there's unanimous support for agreeing that the landscape for diabetes care is not an equitable one in our country. And there is widespread support for doing something about it. So that includes innovative solutions, outside the box thinking, and ideas even up to and including manufacturing insulin and providing it as a state benefit to those individuals who cannot get it affordably any other way. And that's kind of where we are right now. And I think that it's great that we are looking at every option that might be available to us to meet this important goal.
Dr. Koliwad, can you tell us about what biosimilar products are?
Absolutely. So biosimilar insulins are a more affordable, less expensive to manufacture mimic of brand name versions of very similar insulins. And therefore, because of the similarity in action and effectiveness, they are referred to as biosimilar insulins. And because of the lower production cost for these biosimilar insulins, the major manufacturers of insulins have used the availability of these as a way to curb prices and provide more affordable insulins across large populations, both in the United States and abroad. However, because of the economic model for healthcare delivery in the United States, there are a lot of factors that determine the enrichment in anyone's healthcare plan by these biosimilar insulins, and therefore the availability of a biosimilar insulin as a substitute for another branded or otherwise produced insulin version. And because there's a lot of inconsistency in the decision-making around the economics of whether to include or exclude a biosimilar insulin in anyone's options of choice when they go to the pharmacy, biosimilars on their own have not been the widespread success in lowering insulin prices broadly across our population as was hoped they would be. And so without an interactive approach linking legislative rulemaking and the technology of developing cheaper insulins, it's not necessarily the case that we can expect things like biosimilar insulins on their own to just solve the problem simply because they exist.
Can you please share with us what UCSF, you and your department colleagues are doing to address this treatment?
That's a great question. I think that increasingly academic medical centers bear a responsibility for managing individuals with diabetes who cannot either receive adequate care or benefit from the care that they might have access to locally, and therefore serve as a mechanism to prevent poorly controlled diabetes and associated complications across large regions within their states. And in California, in the large Northern California region that UCSF serves proudly, I am committed, our division is committed, and our institution, UCSF, is committed to doing everything it can to improve equity and reduce disparities for diabetes in our large region. And that includes virtual care. That includes provision of resources ranging from pharmacy resources to nursing resources to physician resources to people who live, in many cases, large distances away from our main campus in San Francisco, and also advocacy-related and research-related programmatic impacts that can benefit populations that reflect the diversity of our region. And so we have programs focused on the Hispanic Latinx population, programs focused on the African American Black population, programs focused on Native American and Indigenous populations. And because of the strong cultural and genetic links to diabetes risk in different populations around our region, these kinds of tailored, customized approaches are necessary. And UCSF is doing everything it can to break the envelope and provide innovative solutions along these lines. So I'm very proud of the things that UCSF is doing to make progress in diabetes management.
Definitely an important topic and one to watch looking forward, both in California and beyond. Thank you so much for joining us today, Dr. Koliwad.
Absolutely. I appreciate the time. Thanks, Alice.
Thank you. We've been joined today on As Prescribed by Dr. Suneil Koliwad. He's Chief of Endocrinology at UCSF, as well as an expert in diabetes, obesity, and metabolism. Thank you for tuning in today to As Prescribed. I'm Alice Wertz.
As Prescribed, every Thursday at 1:30, right here on the Bay Area's news station, All News 106.9 at AM 740 KCBS, and streaming on the Odyssey app. The proceeding was sponsored by UCSF.